Dr. M.D. Anamul Haq come on the dais to preside over the session.
Million people suffer from asthma worldwide, and 250,000 asthma deaths occurred every year in 2005. And by 2025, there will be additional 100 million people with asthma in the world. According to NAS, 1999, 5.2% of total population were asthmatic. And very interestingly, pediatric population is more than the adult population. 7.5 of the total pediatric populations of Bangladesh are suffering from asthma. Exact etiology of asthma is unknown, but we know and we can identify different allergens, different triggers. These trigger factors are allergens, indoor, outdoor, and food allergens, pharmacological agents like aspirin, beta blockers, physical triggers, physiologic factors, stress, viral and bacterial, upper respiratory tract infection, rhinitis, non-allergic. In case of non-allergic asthma, occupational exposures, and so on. Depression of asthma, is a complex inflammatory reaction, the inflammatory disorder of the airways, which are known as hypersensitive, and many cells and cellular elements take part here. Pathology of asthma, you can see here normal lungs and asthmatic gland, and normal bronchiole and constricted and edematous asthmatic bronchiole. Asthma pathophysiology has and specific pathophysiology, there are increased mucus production, mucosal swelling, bronchial muscle contraction. And I have already shown acute and in late stage research. And classification of asthma, the working classification, intermittent asthma, persistent asthma, acute exacerbation, and special variants. And persistent asthma, mild, moderate, and severe. Persistent and acute exacerbation may be mild, moderate, and severe. And it can be in all cases like intermittent or persistent asthma. Special variants are seasonal asthma, exercise-induced asthma, diet-induced asthma, variant asthma, and occupational asthma. Stepwise pharmacotherapy treatment program for varying severities of asthma. It's mild intermittent, and it needs step 1 management. Mild persistent, it needs step 2 management. Moderate persistent, it needs step 3, and severe persistent asthma step 4. And classification of asthma, mild intermittent, days with symptoms. We have 2 or less than 2 daytime symptoms per week, and night nocturnal symptom is 2 or less than 2 per month, and FEV1 or FEF is 80 or more %, and PEF variability less than 20%. In case of mild persistent asthma, daytime symptoms 3 to 6 times per week, and more than 2 times nocturnal symptoms per month, and here also FEF or FEV1 is 80 or more than 80%, and PEF variability is 20 to 30%. Moderate persistent asthma, daytime symptoms irregular every day, and more than 1 time per week nocturnal symptoms, and here FEV1 is in between 60 and 80, and PEF is more than 30%. And severe persistent asthma, daytime symptoms, continuous and frequent nocturnal symptoms, and here less than 60% FEV1, and FEF is more than 30%. We should suspect asthma if we find recurrent episodes of wheeze, troublesome cough, especially at night, cough or wheeze after exercise, cough, wheeze or chest tightness after exposure to airborne allergens or pollutions. Course, go to the test or take more than 10 days to clear. Diagnostic testing, peak airflow, expiratory flow, it can be done in home, and what it should not be used for diagnosis of asthma. And very important, and diagnostic testing is permitted with reversible test, and also in some cases like variant asthma, methylcholine challenge test, and where in some cases where the testing is not possible, then we can give diagnostic trial of anti-inflammatory medication, preferably corticosteroid or an inhaled bronchodilator. Management of asthma therapy goals. The goal of asthma therapy is to control asthma so patients can live active, full lives while minimizing the risk of asthma exacerbations and other problems. Goals of asthma therapy: prevent chronic and troublesome symptoms, maintain normal pulmonary function, maintain normal activity levels, prevent recurrent exacerbation, provide optimal pharmacotherapy, meet patients and families' expectations. Drugs of asthma usually relievers, preventers, and protectors. These three kinds of drugs of asthma, you know everyone. Asthma drug classification: controllers and relievers. Controllers include anti-inflammatory drugs and sustained bronchodilators. And relievers are short-acting beta agonists and anticholinergics like ipratropium bromide. And principles of step care management. And step 1 to step 5. Step 1, short-acting beta agonist as per need, and step 2, low-dose inhaled corticosteroids or nicotine antagonist or full-dose hormones or sustained-release theophylline plus step 1. Step 3, high-dose inhaled corticosteroids alone or low-dose inhaled corticosteroids plus long-acting beta agonist or low-dose inhaled corticosteroids with slow-releasing theophylline or LDICs with full-dose hormones, and here leukotriene antagonist can be supplemented. And in all step 1 should be added. Step 4A and step 4B. Step 4A, high-dose inhaled corticosteroids with either LABA or slow sustained-release theophylline. And in here we can supplement leukotriene antagonist or ipratropium bromide. And step 4B, high-dose inhaled corticosteroids with both LABA and sustained-release theophylline. And here also supplemented, and may be supplemented by leukotriene antagonist or ipratropium bromide. And step 5, the last step, oral steroid with all medications of step 4 and step 1. Step care management for 5 years or less than 5 years babies. Step 1, as per before previous slide, short-acting beta agonist as per need, and step 2, low-dose inhaled corticosteroids or nicotine antagonist or full-dose hormones or slow sustained-release theophylline plus step 1. Step 3, medium-dose inhaled corticosteroid or medium-dose inhaled corticosteroids plus long-acting beta agonist or medium-dose inhaled corticosteroid plus sustained-release theophylline or medium-dose inhaled corticosteroids plus leukotriene antagonist with step 1. Step 4, high-dose inhaled corticosteroids or high-dose inhaled corticosteroids with LABA or high-dose inhaled corticosteroids with slow-releasing sustained-releasing theophylline or high-dose inhaled corticosteroids plus leukotriene antagonist plus step 1. You know, poor patients of our country cannot afford the standard step care management. So, for the poor people who have made step care management, that is economic schedule. There is step 1, short-acting beta agonist like salbutamol syrup or tablet as per need. And step 2, oral plain aminophylline or theophylline 2 to 3 times plus step 1. Step 3, oral plain aminophylline or theophylline plus oral long-acting beta agonist, that is bambuterol. It is available in your country 10 to 20 mg at night time. And plus step 1. And step 4, oral steroid, preferably prednisolone single morning dose 5 to 20 mg plus all medications of step 3 plus step 1. Other option in step 5, there are new therapies like omalizumab, a monoclonal antibody against IgE, may prove helpful in atopic patient. Steroid-sparing agents such as methotrexate, cycloserine or oral gold may be considered. And some other immunotherapies also may be tried. And how to step down? Once control is achieved and sustained for 3 months, the reduction of drug therapy step down is appropriate and helpful to determine the minimum therapy for maintaining control. Reduction of therapy should be slow and gradual. Reduce the dose of inhaled steroid by 25% and sometimes it may be up to 50% from total dose up to minimum low dose. After withdrawal of steroid, gradually stop protector drugs at 3 months interval. And Mr. Chairperson, in conclusion, I like to say asthma is a chronic condition, but effective treatment is available for the majority of patients. For effective control of asthma, step care management is essential. Every asthmatic should be evaluated about their severity of symptoms and should be selected appropriate step care management, and by this step care management, the patient can be doing well throughout his life. And thank you very much.
Thank you, Dr.